please. Dr. Vijay Shekhar, please, sir.
Thank you very much, sir, for the kind introduction. And good morning, good afternoon, good evening to all the people at different parts of country. And I would like Eddie to please share my slides. And thank you for the opportunity, the PGSSC team. And can I have my slides, please? Greetings from Visakhapatnam, India. Friends, today I'll be sharing some of our experiences from India. Next slide, please. Greetings from Andhra Medical College. Friends, I'll be discussing for a couple of minutes, and my outline of discussion will be on the present burden and the existing guidelines in India. Then what are the recommended policy guidelines which already have been shared by Camilla. Then what are the gaps between the existing guidelines in India and the comprehensive recommendations. Then how to fill these gaps, especially by way of training and education with the special reference to India. So this will be my plan of talk. Next slide, please. Friends, the India has a vast area and it is very difficult to get all the information pertaining to health or medical conditions. However, with the continuous efforts of the government of India, we have formulated a condition called National Health Portal. This system has been developed, which is an authentic system with all the data. Way back in 2014 itself, the government of India has identified the concept to catch them young and intervene early. So that is the one. With this concept, the government of India has started a project called District Early Intervention Centers, DEICs. So you can see in the DEICs, also there is a RBS, that is Rashtriya Bal Swasthya Karyakram. So under this program, the government of India has identified all the existing pediatric conditions which can be improved by intervention, focusing mostly on 4 Ds, that the disorders of congenital, the deficiency diseases like anemia, protein energy malnutrition, the congenital disorders like congenital heart disease, and developmental disorders like autism, hearing loss, visual loss, so on and so forth. So focusing on all these things, the government has already started emphasizing. For example, friends, you can see there is to combat the cleft lip and cleft palate cases, we have an initiative called Smile Train program, and the government has included the congenital heart diseases and cochlear implant for the auditory impaired children, which will be done free of cost through the government agencies. Similarly, a club food initiative. Friends, on the right side of the screen, you can see several programs which are being managed by these district early intervention centers. However, you can see there is no place here for the spina bifida and hydrocephalus. So this is the area where we have to educate, we have to emphasize the government that these 2 conditions also to be included in these childhood disorders, so that these district early intervention centers can be supported and strengthened. Next. So after looking at this, how we can do the risk stratification and holistic approach with special reference to education. Health education and awareness is very important thing which will be required at all levels, especially all the healthcare workers as well as the general public. Friends, what all said and done, the India is the second most large populous country in the world, and still the television, cinema and social media are the most catchy mass media which can be emphatically drive any concept into the people. So with this health education, we can take the concepts into all the healthcare workers as well as the public. Similarly, coming to the preventive strategies, as already have seen, the most commonly used thing is salt fortification with iodine. So this was most popularized not only in India, in also other countries. So a thought has come, why can't the rice also be fortified? The rice grains or rice kernels are fortified with micronutrients like iron, folic acid, and vitamin B12. This was actually started in the Andhra Pradesh as a pilot project at one district. However, if the same fortification project which was started as a pilot project, if it can be taken at a large scale to the entire nation, then we can have prevention of these congenitally malformable diseases. Similarly, this flour and rice can be used only by certain population. It may not be reaching to everyone. However, if we fortify the salt, the concept of quadruple fortification of salt, QFS, that is already iron, iodine, folic acid, B12. If the salt can be fortified with these, that also will be helpful. Then coming to the antenatal history, we can identify the high-risk mothers. This history taking can be done by not only the doctors or OBG specialists, but even a staff nurse or paramedic or anyone specialized can take this history. So we have to emphasize the training of our education to take a proper antenatal history where we can identify the high-risk mothers with gestational diabetes mellitus or mothers who are using the teratogenic drugs or polyhydramnios. Once with the history, a high-risk mother is identified, then we can subject them to TIFA scan. We can closely follow up and appropriate decision and MTP can be discussed with the family. Next, please. And friends, these are some of the things in line with the sections which are given in the comprehensive guidelines. Coming to the antenatal screening, all the green things which are shown on the screen are already existing in our country. For example, in the antenatal screen, each PHC or each dispensary are provided with ultrasonography machines which are available at every healthcare provision. So, however, there is a gap. The machines are available, but radiologists are not that many in number. So what we have to do is we have to educate and we have to scale up the radiologists for these services. Similarly, once there is a...
Could you summarize 30 seconds to me, please? Thank you.
Yes, sir. So similarly, we can early intervention and rehabilitation should be followed once there is a surgery, and individual level should be given. Next, please. So, how to educate and whom? All the neurosurgeons should be trained by continuous medical education workshops. All the non-surgical doctors and paramedics also should be recruited by CMEs, and the parents and public should be especially even the mass media like YouTubes and all, and the youth, especially the social media, flyers, mobile apps and all. Next. So these are the various methods. We invariably get some ads in the YouTube, television, short films, flyers. So health education. So these things we can take benefit in educating and training the masses. Next, please. So friends, to conclude, we have to support, then disseminate the knowledge, and then implement. This should be by way of including the spina bifida and hydrocephalus in the national health programs, then developing registries, then dissemination of knowledge through information, education, and communication, implementation by helping the training for the diagnosis, surgical aspects, and also the continuing the rehabilitation and transformation. Thank you.
Thank you so much for that presentation, Dr. Vijayashekhar. Our next panelist, Dr. Jeff Blount, is a professor and chair of pediatric neurosurgery at the University of Alabama at Birmingham in the US. He was active in recently published sets of clinical guidelines for care of patients with spina bifida and is the former chair of the Professional Advisory Board of the Spina Bifida Association of America. He is the founder and co-director of the Global Alliance for the Prevention of Spina Bifida Type F, which is a global alliance for science-based advocacy for folic acid fortification of food and salt. In his talk, Dr. Blount will focus on folic acid simplification and fortification. Welcome, Jeff.
Well, good morning. Thank you for the opportunity to participate in this. I think it's a remarkable resource, and I'm really glad to join some of my friends and colleagues. And while listening to the others, I scanned through some of the participants, and I'm really pleased to welcome and see some of my colleagues and friends who have been so active in this role. Well, this talk and this brief 5-minute summary is to underline the importance of advocacy for fortification. Why now? Why is this not just a background thing? It's been hanging around for years. Every talk says something about fortification and it sits around comfortably in the background, but we hold the position that it's time for that to stop. It's been 30 years almost exactly since we have class 1 evidence showing the effectiveness of folic acid fortification. There are very few things in surgery for which we have class 1 evidence, and this has sort of sat in the background while some parts of the world have moved toward fortification, others have avoided it or opted for other strategies, including screening and termination and things like that, which have their own problems, which are only partially dealt with sort of in the medical literature. At present, there's about 56 countries that fortify. What that represents less than 25% of the global burden of preventable spina bifida. Now, we've talked about spina bifida as different types. Spina bifida X is the idiopathic type where we don't know what it comes from. Spina bifida F is the type that's folate sensitive, which may represent up to 92%. One of the questions taught in the chat talked about other prevention strategies, and that would focus on other risk factors such as maternal diabetes, which is your obesity challenges. So low and middle income countries are fighting both caloric deficiency and caloric excess. High rates of obesity correlate with that risk factor. Other things, valproic acid is a known teratogen that adversely impacts folic acid fortification, and it's a widely used seizure medicine. So there are other strategies, but the by far most important strategy for prevention of this disorder is the fortification of vehicles for folic acid. That is by far the biggest, most effective thing. And we as a surgical community have a bigger role to play. Why now? There have been some hotspots that have emerged. A baseline background rate of spina bifida in fortifying countries is 8 cases per 10,000 live births. 8 per 10,000 is what can be achieved and is repetitively achieved around the world when fortification is pursued. And I say that carefully, not supplementation, but fortification. And the reason why is that most pregnancies occur not by planning, but by accident. And the defect occurs before most women realize that they are pregnant. So supplementation at the time the woman realizes she's pregnant, the defect has already occurred. Study after study has shown fortification is the approach, not supplementation. Surgery is playing a bigger role than it used to in global health. The Lancet Commission report has been fundamentally revolutionary. What are the concepts by which we've organized as a group? This started as a neurosurgical group because we have a front row seat on this. We have a unique vantage point that I'll emphasize in just a moment. These are the fundamental concepts. One, this is safe and this is effective. There are new vehicles that are available. This is a very exciting time. SALT looks like it may be an effective vehicle. We're in the early parts of doing the SALT studies to see how much salt at what rate to which folic acid has been placed where blood levels haven't gone up. When blood levels go up, rates of spina bifida go down. It's that straightforward. It's that simple. Folic acid is a tough molecule. It binds well to a variety of different vehicles. Time is important. Inaction and doing more studies and delay and delay and delay costs several 100,000 births every single year around this world that are preventable. This is a low-cost, high-impact public health thing for which neurosurgery is potentially in the front seat. Only a small percent is being prevented. Science-based advocacy is the cornerstone of our world, and we have powerful networks. These are the concepts by which we organized our alliance because we think it can have a strong voice. We think in neurosurgery, we have a little bit of a unique vantage point. We see this disease from beginning to end. Transitional care is increasingly important. The in utero programs have emphasized our awareness of how important our role is at the table early on. This is not the domain solely of maternal fetal medicine or high risk obstetrics. Nelsie and others have emphasized the role that neurosurgery can play early on in counseling and guiding families. We see this disease, others do not. Others see it for individual points. We see it from prenatal all the way to adulthood. That's a unique perspective. We have a unique relationship with patients, parents, and advocacy groups. We self-activate each other. Neurosurgical interest and support of advocacy groups is like oxygen to fire. We can stimulate these groups, we can support these groups, and a little bit of neurosurgical investment results in massive returns. The UK and New Zealand just made notice that they were going to fortify. What drove it in the UK predominantly? A parent-driven group. What drove it in New Zealand? Predominantly a parent and advocacy-driven group. So we can interact with these people in a unique way such that the potential of neurosurgeons working with other neurosurgeons in non-fortifying countries and parent and advocacy groups is probably pretty close to unparalleled. We're playing a bigger role in global health, and the sort of unique qualities of neurosurgery, I think, also play a role.
Jeff, can you take about 30 seconds?
You bet. We started with neurosurgeons, but we've expanded to experts in epidemiology. We have colleagues and friends that are doing this work. I saw Dick Koenig and his brother, Rick Boop, all on here. These are the people that are literally doing the work, that are dedicated to doing this work around the world, and they've done some remarkable things. We have a number of initiatives underway. We're writing papers to provide these cornerstones of information for busy neurosurgeons so they can partner with their ministers of health and not have to do the work themselves. This is a slide deck that's available to neurosurgeons. We've done the research. We will support. So we need people to reach out. What can you do? You can understand what's going on in your country. You can join GABSFI. You can participate. We would love to have anyone who is interested in participating. And with that, I'll close for time's sake. Thanks, Yogi.
Excellent, Jeff. Excellent. Thank you for that overview of prevention and efforts. Next, I invite Jakob Ahmed. Eddie, if you can help with the slides. Jakob has 10 years plus experience in the Ministry of Health in Ethiopia. He's now a Fulbright Scholar Fellow. He's working currently in Virginia Commonwealth University, but he brings a wealth of information about how can we take this and prevention efforts to the government. And I think he'll give us more perspectives from Ethiopia. Welcome, Jakob Ahmed. I don't see Jakob here. What, did he drop off? He was here a minute ago. Jakob, are you here?
Yes, I'm here. Can you see me now?
Yes.
Yes, we see you. We see a picture. Thank you, sir. Turn your camera on.
Can you see the slides now?
Yes, we see the slides. We'd love to see you too. Thanks.
Okay, thank you very much.
Your camera's not on, Jakob. Thank you.
Thank you. Now, I think it's visible, right?
Yes, sir.
So thank you very much. So my talk will be very short, and it will be a summary of what the previous speakers has been said. So I just want to start. I would love to start with a summary of my story, but I don't want to go through all the stories. These stories happened like in 2016 when I was a CEO of one of the hospitals in Addis Ababa, which is St. Peter's Specialized Hospital. And we had like an effort to improve a neonatal ICU in that specific hospital. And finally, it ended up with opening a neurosurgery department to improve the neonatal ICU unit, which is a very different experience because of the significant number of spina bifida hydrocephalus cases has been sharing services at neonatal ward, neonatal ICU, and many neonatal service units. So because of Dr. Mersha, neurosurgeon, and Dr. Kamfani, anesthesiologist, they're able to establish that neurosurgery unit in a couple of months, and they start to operate the kids. Once they start to operate the kids, the problem aggravates. Lots and lots of number of patient has been referred to that specific hospital throughout the country. And in 1 month, we registered more than 225 cases in the waiting list. This is a story, so you can read it once I share the story, but I don't want to go through detail. From the story, you can take 2 very important points. The first important point, as a low and middle income country, in my country, Ethiopia, it's very difficult to establish a pediatric neurosurgery unit. It's expensive, it's complicated, it's time taking, and it needs so many things because there are few number of neurosurgeons, equipment, supply, technology availability is very few. So it's really expensive for a country like mine. And the other thing what I learned is MTD cases, especially hydrocephalus, spinal bifida cases are also competing care with other preventable illness neonates. There are in ICU, in wards, so even they are not only dying, they are also contributing with the deaths of other neonates with other preventable illness. And the demand for the surgery is high. Whenever you have the surgical care, the number of patients will be high because there is a demand there, unmet demand there. So you cannot really answer the case by improving surgery only. So this is the hard way. As a hospital team, we try to establish the neurosurgery, but I learned in the process is the hard way of doing that business. And when I moved to the Ministry of Health, I learned that has to be done in better way. I thought there was an easy way, which is a policy intervention, which is a prevention, what everybody was talking about before my speech. So this either way is our choice. So we have to choose either way, the hard way or the easy way is, I think it's our choice. So I can give you just one example. If we choose the hard way, this is an article published recently in known journal, published by Richard Adler Foundation, like Dr. Koning, John Koning, Professor Oakley from Emory, Vijay from Emory. They published one article about the neurosurgery workforce estimation. If Ethiopia doesn't interfere the problem, if it maintains as it is, we have to train neurosurgeons for the rest of 20 years to fulfill the demand of the current growing number of spinal bifida hydrocephalus surgery. So you can imagine by only 2039, we can achieve the minimum number of neurosurgeons. If we keep on training with the current capacity and if we keep on the problem unattended, just if we use the surgery as the only solution. So this is very, very difficult to really achieve. And if we choose the easy way, that's everyone is talking about the fortification. If we choose the easy way, if we're able to add folic acid in wheat, especially on the current iodized salt. So the wheat is consumed by very few number of community in Ethiopia, but salt is consumed by majority of Ethiopians. So if we're able to add folic acid in the current iodized salt, you can see the current estimated number of spinal bifida and hydrocephalus, anencephalus cases are 40,000 plus based on hospital-based study done in 2018, estimation of from 3.3 million live births. So if you see in just 2 years, you can reduce it by 90% if we're able to add folic acid in current iodized salt. This is a very easy way, safe way, as already Dr. Jeff Blunt clearly said. And it's not only like minimizing the case, but we are also preventing the stillbirths and under 5 and neonatal mortality at the same time. So this is the easy way. So as a last point, so as action globally, not only in Ethiopia, but also globally, I think we need action now. Babies are suffering, dying, and neurosurgeons are asking. They want to save life due to trauma, due to accident, due to other pathologic cases, cancer cases, oncology cases. There are a lot of patients to deal with in their hospital. Also, this is like a preventable problem. So we need to work on prevention. I think that's why we need action now. I think leadership is very important, especially collaboration. Leadership is very important. And I recommend globally, we need to choose the easy way instead of the harder way. So every one of us as a global health professional, we need to advocate for choosing the easy way. Advocate for what? We need the WHO resolution. WHO has passed a number of resolutions in the past many years to tackle public health problem globally. So we need now mandatory fortification of folic acid in low and middle income country has to pass as a resolution in WHO. So GASP, Dr. Jeff was taking care of that. I think we as a global health professional should be in the back of them, and countries should take leadership to have a global resolution on that. Second one is funding. If you see the neurosurgeons in low and middle income countries, especially in my country, residents in my country, if they want to do small scale research, it's very difficult for them to get funds. Partners are interested to fund giant macro research, but for me, small scale research, feeding research, organoleptic research, supply chain research, and regulation research, surveillance and data capturing research in hospital level is very, very important to inform policymakers, the person who is working in a ministry, WHO, or any global health. So I think we need to advocate for small scale funding for neurosurgeons, for residents, for public health professionals to do in their respective country. And finally, the comprehensive approach. So I was part of the development of the neurosurgery comprehensive document and comprehensive approach. We cannot avert this problem by neurosurgeon only, by training only, by prevention only. So we need to have a comprehensive approach, and we call it in Ethiopia, we call it Neurosurgery Center of Excellence. Pediatric Neurosurgery Center of Excellence, with the help of Rich and as a foundation. I'm seeing them in the participant list, Dr. Koning and his brother. They have been helping us to establish Neurosurgery Center of Excellence, where there is a prevention of high-risk mom, where there is a community ownership, aftercare, surgery, and training program. All they have to come in one basket, and then they can change the life of the kids, the moms, and also as a whole the community health. So these are this should be the takeaway for a global health, and Harvard team should also advocate for this for the rest of the time. Thank you very much for the opportunity. This is my second time in this platform. I'm very much privileged to be part of the team. Thank you very much.
Thank you so much for your really interesting talk, Ahmed. So it's a privilege.
Can I interrupt you just for 1 second? I just wanted to add a single sentence to underline that great talk by Jakob. Can I just one quick second? I know we're running a little.
Go for it.
So what Jakob just did is made a really important point from a policy perspective, that it's cheaper. There's a hard way, there's an easier way. We must remember that every procedure that we do across the spectrum, whether it's urology, orthopedics, neurosurgery, whatever, is largely palliative. It does not correct the condition. This is not fixable. It's not like a benign brain tumor that can be taken out, an abscess that can be drained. We don't fix spina bifida by going down the hard pathway. We treat symptoms and take something that is impossible with high mortality and bring it back to something that's still lifelong, exceptionally difficult, which is fundamentally different from preventing it in the first place. So it is easier, cheaper, and it is the difference between lightning and lightning bugs in terms of its effectiveness. That's it.
Thanks a lot, Jeff. Really good point. Now it's a great honor to introduce our last panelist. Dr. Andrea Winkler is a neurologist and the co-director of the Center for Global Health at the Technical University of Munich in Germany. She is the founding director of the Center for Global Health at University of Oslo, where she also holds a full professorship in global health. She's also co-chair of the Lancet One Health Commission. She has been working closely with the neurology unit at the Department of Mental Health and Substance Abuse at the WHO for many years, and was invited to give input to the WHO Global Action Plan on epilepsy and other neurological disorders. And today she will explain what a global action plan is, why the WHO Global Action Plan on epilepsy and other neurological disorders is important, and how it can serve as a catalyst for documents such as the CHYSPR document. Welcome, Andrea.
Well, thank you very much, Camilla, for this very nice and kind introductory words. Thanks for the invitation also to Yogi and Ki and all the participants in this really great initiative, and it gives me great honor to hopefully be able to give you a glimpse into the bigger picture and to follow Jakob's talk. Couldn't be more suitable. I think this is a very nice transition. Eddie, next slide, please. So yes, my affiliations, it's the University of Oslo and the Technical University of Munich. I just want to, I know I only got 5 minutes and we are very late already, but just to give you a brief overview how this, it's now the name is slightly changed, the Intersectoral Global Action Plan for Epilepsy and Other Neurological Disorders has come about. It has been a major achievement of the newly founded Brain Health Unit, which is based at the Department of Mental Health and Substance Abuse at the WHO. Previously, neurological disorders and psychiatric disorders have been actually put into one under one umbrella, and now that is already a really great achievement. The neurological, the neurology and neurological issues have been singled out, and the Brain Health Unit has been created, and it's led by Tarun Dua, also from India, Yogi, so you may be pleased with this. The first real step they have taken was to get a resolution on a potential global action plan for epilepsy and other neurological disorders. So we have this Brain Health Unit at the WHO now that we should tap into. At the same time, so that was now COVID-19 had hit us, and at my university in the Center for Global Health, then co-directing at the Technical University of Munich, we found it at that point in time, which was 2 years ago, roughly, a little bit less, a global COVID-19 neuro research coalition. And through that coalition, we started really intensely collaborating with that Brain Health Unit. I'd be loosely collaborating with them on various guidelines already for the last 10 years. And this is how we got actually involved into the notion of what a global action plan means. There are various global action plans, not only on epilepsy and other neurological disorders, and what the significance is. So basically, a global action plan at WHO means that specific attention is being given to that topic. It will be put high on the agenda. Resources will be pooled, and last but not least, and that's important, implementation in the member state countries will be enforced, because a global action plan will be commissioned and has to be agreed by all the member states. So next slide, please. That is the overall picture, how we got involved, and we were able to publish that as a short commentary in The Lancet, particularly how we, as the coalition, the Global COVID-19 Neuro Research Coalition, could support such an action plan. And then working with Camilla, I came across your tremendously important comprehensive policy recommendations for spina bifida and hydrocephalus in low and middle income countries. And we immediately felt that this also could be a win-win situation to basically bring that knowledge into the global action plan, but also use the global action plan for the implementation of our comprehensive policy recommendations. So it's really bilaterally. So to cut a long story short, I cannot use a cursor. So top left corner, this is the resolution. You can see the World Health Assembly, which is the parliament of the WHO, is passing the resolution. And then a resolution has to climb up some steps. And these are the blue steps that I just put in between to become a discussion paper, because the public is always invited. So the member states are suggesting, and the member states will also ratify. So you have a zero draft, and that was in January 2021. And then this is now pushed up to May 2022, when hopefully the suggested paper, and then there's now a newer version of it, will be ratified or will be agreed by the member states. So what is the overall aim? And so just gonna outline the overall aim, and then I have a last slide or two slides where I will look at issues where there is a win-win situation for our policy recommendations now and on spina bifida and hydrocephalus. So the overall aim is to reduce the impact and the burden of neurological disorders, and the burden, of course, mortality, morbidity, but also there is a huge focus on disability, which is very important, quality of life, and the important is all ages. So it takes a life course approach, and the children are right there. So that's important. You may be surprised that epilepsy is at the forefront, and it says epilepsy and other neurological disorders. It has been discussed many times, but it is really technical and also political. That brain health unit started out with lots of technical support, guidelines, etc. for epilepsy. Hence, epilepsy has been really flagged high, then also a bit of dementia and headaches, but the whole breadth of neurological disorders has not been tackled, but it will now be tackled in this action plan. Next slide, which hopefully will be, as I said, ratified now this year, the next World Health Assembly 2022 in May. These are the guiding principles. I'm just going to read them out quickly. We can discuss them another time. We can also just have a seminar on the bigger picture. So basically, that intersectoral global action plan will look at people-centered primary health care, but it will include the big picture of the universal health coverage, which has been discussed extensively in the global health arena. Integrated approaches are important, evidence-based, and this is where we come in. So evidence, evidence, evidence. It's again it's a win-win, a two-sided approach, very bilateral. The life course approach I've already mentioned to you, the intersectoral action. So we need the politicians, we need the NGOs, we need civil society. As it was said before by Jeff as well, that advocacy, it actually came from the patients, or better from the parents of patients in case of children. Empowerment of people affected, gender equity. Here we have the poorest of the poor very often can't reach. Children have got hydrocephalus that cannot be treated anymore in low and middle income countries where we have worked. So all of this is there, and we need to use it for our recommendations. Last slide, please. Oh, sorry, yes. So our recommendations just need to be put on top, and not just that, but also be integrated. Next slide, Eddie, thank you. That's my last one. It's not just, there's not just any global action plan, but of course the global action plan from WHO is one of the most important ones. There's also a new notion, it's not that new, but it's very new now in the public field, which is One Health. You've heard of it. It's been sort of entered politics and also ways of collaborating through the pandemic. I just want to say this is another concept that could be applied to hydrocephalus, bearing in mind that quite a lot of hydrocephalus in low middle income countries is infectious and parasitic, very often also through the animal route, and the environment around this is important. I stop here, but there are other bigger pictures that our joint recommendations could be integrated. Thank you very much.
Thank you, Andrea, and all the speakers. I know we're running a little late, but we had some issues with the Zoom update. Eddie tells me, and some people had troubles joining. With the permission of our speakers and my dear friend Key Park, let's take about 5-7 minutes over just to finish. We would request anybody who has questions to please turn on your microphones and your cameras and ask directly to any of the speakers. If you can keep it to 1 or 2 sentences, that'd be wonderful. We appreciate the time. Camilla, would you lead off the discussion portion, please?
Sure. So as Yogi said, if you have any questions, just raise your hand or just take the word, basically, yes. So if there isn't any for the moment, I can just start off. So we have this, we've heard a lot about spina bifida and fortification in this talk. So this document also addresses hydrocephalus, of course. And I'll direct this question to Nelsie. So, you know, to introduce the hydrocephalus issue a bit more, another cause of hydrocephalus and many LMICs is, of course, the post-infectious type. due to neonatal sepsis. So what is your take on how ministries of health may address this major challenge?
Thank you, Camila, for these questions. Yes, the infection is a great difficulty for us to deal, and hydrocephalus after infection is for time life problem for the children. I think we need to focus not on treatment, because treatment, each neurosurgeon have different ways to treat. The main focus need to be done with prevention. Infection, like we are talking about spina bifida prevention. If we can help the children, help the people, we need to focus in integrate team, nurses, doctors, pediatricians, neurosurgeons, obstetricians, try to avoid infection is the message. Thank you for your kind question, Camila.
Great. The prevention perspective is really being emphasized throughout all of the talks, which is very essential. Jeff, would you have another point to regarding that?
Thank you. Yeah, very, very much for the opportunity. I think that this notion of infection and prevention is really a promising one for the future. If you notice, Ben Worf's work along with Steve Schiff has pivoted, and they've now written recently, meaning over the last 2 to 3 years, about how the incidence of hydrocephalus seems to follow rain patterns in some areas of the world. And this may have to do with a cultural piece where the housing is secured with dung and things like that, and it may be an exposure thing. So I think the question with regard to hydrocephalus and post-infectious is spot on. I have no new data or insight to bring to the discussion other than to encourage people to keep watching the publications of the Schiff, Ben Worf axis, because I think that's a really thoughtful group that's working hard on this.
Thank you so much. Key, do you have a question for our panelists? I'm asking Eddie to chime in.
Andrea has a raised hand too.
Andrea has raised your hand. Please, Andrea.
Please, Andrea.
Just a very quick reaction and to preventative aspect. We also should think about health promotion and sharing of the knowledge. So that, of course, feeds into the prevention. And there are some really nice new technology, especially also for low and middle income countries where you can't reach hospitals in time, where you don't have access to, let's say, even a television, but you will have access to to internet. It can be fixed even through innovation. So then you could also access health knowledge. We shouldn't say education anymore, but it's the sharing of the health knowledge, and especially maybe in the antenatal care clinics, mothers could already be educated, which I'm sure it's the case in many parts. And also the Global Action Plan, just one last word, the Global Action Plan emphasizes promotion. Now you need to remember prevention, protection, detection, treatment, and management. So it's all the way from really giving information, then leading to prevention once it happened. Then, of course, you need a good management, good guidelines, but also the health system at large needs to be strong in the infrastructure. Thank you very much.
I see a hand up by Swami Yogishananda. Is the hand still up, sir? Do you want to say something? Oh, the hand is down. Okay. Key, did you want to ask a question or say a comment before I ask a question?
No, I'll wait till the end.
I would humbly request Vijay Shekhar and Jakob to speak about how do we take this to the people at large who have the power and the money. Now, Jakob, your points about less expensive route is excellent. Education, Vijay Shekhar, you mentioned, multimedia, etc. Somehow you two can join and give us a synopsis of what the next 2-3 steps would be. One of you, please start.
Oh, thank you. I think just to add one sentence. So everyone is working toward this one goal. I hope so. It's just to reduce mortality, this morbidity, and also suffering for the kids, the families, So we all are agreeing on prevention. So I think the next step should be for me pushing to WHO. I personally believe WHO World Health Assembly resolution is very important for mandating adding folic acid in one of the staple foods in low and middle income country based on their respective country culture situation and food items. So I think I personally push, we need to push towards this WHO resolution, having one resolution passed to mandate folic acid fortification for each and every specific country. So I think Dr. Jeff Blount starting the process, and I think he have to get our back. And so we need to work with him and his team so that next year WHO should pass a resolution about this. So that would be the only way to get into every countries, every political leaders, every policymakers easily, instead of like doing all things around there. So thank you very much.
Okay, Jeff, you can go ahead.
Jakob dealt with that very, very well. I wanted to just touch base on two very quick points that have come up both in this question board and in other ones when we've had this conversation. One is, what about antenatal screening and termination? That differs a lot around the world. It's a very difficult topic to talk about for obvious reasons. It's emotionally charged, it's politically charged. I don't have any comments along those lines other than for the participants of the seminar to recognize that while this is difficult to talk about, this represents a major management scheme in very advanced places in the world. Okay, I'm not going to call them out country by country. You all can look at the map. And if you don't fortify, there's basically three choices: do nothing, fortify, or antenatally screen and terminate. It varies in various places in the world. Up to 22, up to 21, up to 20 weeks. I have no comments on that, but this is just a reality. Large parts of the world antenatally screen and then offer termination at a very high rate. That is why incidences are very low in some parts of the world that do not fortify. What I find quite interesting, and again, this is not a political comment, but just from a science perspective, I, in reviewing the literature, can find very little information published about the downline consequences of that with regard to mental health of the families, with regard to the mothers and things like that. No political statement, just trying to look at these different strategies from an across the board perspective. Again, it seems like folic acid in a vehicle seems like a much better route. Point two, people say, well, why would there be resistance to this? And what about all the other micronutrients? Isn't folic acid just a B vitamin? There's other important micronutrients. Yes, that is true. That is absolutely true. And that's one of the places where this work has not received the emphasis from the nutritionist community that one would empirically think that it would. They want all the they want all the micronutrients front and center, zinc and all these other things, stunting, very important problems, to be sure. Points that I would make in this is, number one, folic acid can be the poster child for micronutrient fortification. There's nobody in neurosurgery or in this effort that is saying micronutrients aren't important, only folic acid. It's just that it's a great example of the importance of micronutrients. There's no such thing as a zinc deficiency clinic. There's no such thing as a stunting clinic. So to Yogi's point, how do you get ministers of health to see the problem? Try to take them to a zinc deficiency clinic to see the impact of micronutrient deficiency. It's very difficult. On the other side, working with parent organizations, advocacy organizations, you can bring health ministers to spina bifida clinics and show them this is what spina bifida looks like. This is the suffering that's involved in a best case scenario where we have multidisciplinary clinics, where we have all these other things, and it gets worse from here. So it's not that folic acid seeks to displace the other micronutrients. It's that it's a good example of the other micronutrients. It's safe, it's effective, and we need to kind of clasp arms, join with the parents, join with the other advocacy groups, and collectively work toward more broad-spread fortification of all these vehicles: rice, grain, corn, salt, etc. That's it.
Thanks, Jeff. Thanks. Dr. Vijaysekhar, you had your microphone on. Did you want to say something before we give it the key to close? Go ahead, sir.
No, that is the main point, sir. Actually, either we have to prevent by fortification in the foods, all the various food substances. Not only we have seen, it was excellently demonstrated in the graph, both the flour as well as salt fortification. So that is one aspect. What all said and done, we have to pick up the early cases, the ultrasound of the antenatal mothers, and if it is picked up in the early period, okay, we can advise, we can leave the couple to take the decision. But however, still the problem remains if it is diagnosed after 24 weeks or late. Then what is the laws are different from each country. So that is number one. Once they are born, it will be again a lifelong problem for the child, whether the surgery is performed, whether the rehabilitation is continued, whether the transformation is continued or not, it will be a problem. So always we have to sit with the government, with the lawmakers, and then we have to emphasize. This is a very easy way, very excellently shown by Jakob, the easy way we have to tackle first. However, once we find out a problem, then we have no other go. We have to educate the parents, we have to educate the youth especially, because before conception only these are to be given. So that also to be educated. And once the babies are born, the mothers, the parents are to be trained for rehabilitation. The NGOs will come into play, and then the society and the government. So this is an ongoing process. So everything we need to strengthen.
Appreciate so much, everybody, all the panelists. Without you and all the participants, this would not have been a success. I thank each one of you and the team. I think there's one hand raised by Swad Doedi. A quick comment, madam, because we have to close. We're running over.
Okay, thank you so much, Mr. Jogi. I just have a question for Mr. Jeff. Like, I'm a medical student from Tunisia, and it's an LMIC, it's an LMIC, and I really don't know much about like the situation of spina bifida in my country, but I have a neurosurgery rotation coming up soon, and I was thinking like maybe I can help found a neurosurgical club once exam season is over. We can maybe resort to social media for advocacy, but I really want to know, like, what is it that as a medical student that I can do to sort of help maximize the impact, you know, on prevention of spina bifida?
Outstanding question. I'll be very brief because Yogi's trying to wrap up. We have medical students working with us. You are who we want. We want to connect you with our medical students working at that level so that this thing unfolds at all the various levels. Don't underestimate your potential for impact, okay? You can have a lot. Now, that being said, your first task is to finish medical school, and don't let this get in the way of you passing your examinations and things like that, okay? So we welcome you. If you can reach out to me via my email, which can be available through the, I'll put it in the chat, okay? And I have a helper medical student who's wonderful. So we'll put that up for you here in the chat, okay?
Just one.
Add incision. I'm sorry, Nelsie, go ahead.
Okay, she can join us also on ISPN, International Society of People. We have the president here, Professor Book, and we are just open for medical students and residents. Maybe you can join us too. Welcome, please. Go to the website or send me an email, whatever you want.
All right, sure.
Key Park, it's your turn, sir.
Yeah, well, based on the discussion, it seems like we can have a dedicated session for each one of the presentations, really. Thank you, everybody, for attending. Let's see, a couple of things. By the way, Jan Koenig and Marinus Koenig are twins, so you're not having double vision if you're seeing them on the screen. But I think that I can wrap up this session as follows. Prevention is absolutely essential. It is the easy way. It is the easy way, cost effective, and it's better for patient outcomes, but we can't prevent all of it. And we actually have to invest in surgical systems. So this is where we come together. And I love how Andrea wrapped up this global governance, and there's now a intersectoral global action plan for neurological conditions. And the comprehensive set of recommendations fits so nicely into what they're trying to do. And this is a call for action for all neurosurgeons to start working on policy recommendations for other conditions as well. So I think it's never been a better time for neurosurgeons to get involved with, the global neurosurgery, the public health aspects of neurosurgery. Jeffrey Blount is really the epitome of an advocate in neurosurgery. He's obviously a very good surgeon, but is actually a better advocate, I think, outside of the OR. Excellent job, Jeffrey. And just say thank you to everybody for joining. We will have this recorded and put on our website for people to see afterwards. And thank you, Camila and Jogi, for excellent moderation. And a little shout out to Eddie, our research associate. He's not, I don't see him, but Eddie Ham he's really the person behind the scenes who helped put this all together. Have a great day, everyone, and thank you again.
Thank you, Park.
Thank you.
Key
Bye
and
bye.
Yogi.
Congratulations.
Yeah, thanks to
Thank
Key
you.
and Yogi and everyone. Wonderful.
Bye-bye.
Thank you.
Thank you, Jeff.
Thank you, Key.
Thank you,
Thank you all.
Jakob.
Bye bye.